All right, welcome back. We continue our talk about PVD and PAD, and we have the expert here, Dr. Craig Walker, who's been all over the world. And I remember when you got started, because I was just getting started. And here was a great physician, went to a great college, came back to Houma, started a practice. Now you're going to Germany and China to teach. What an honor.
Yeah,
What's that like to go to Germany and China to teach?
Yeah, it is fun, but it's more of sort of a vocational fulfillment, if you would. A long time ago, we wanted to really improve healthcare. We wanted to do it on the heart. And part of that got me interested in the legs as well, because I realized that the legs were a key to a lot of outcomes. If we could render better care to people who had leg blockages, it could result in better survival as well. And that sometimes this might be the way that we could understand disease that historically we missed. Mm-hmm. I got really interested in this and then became very interested in limb salvage or avoiding amputation as well. And the rest of that is sort of history. We really became very involved in finding better ways to treat this. And so many of the treatments that are now used are things that we started, things that really began first or were first done here in Houma.
But what was that telltale sign that you saw that nobody else was really looking at that told you, go to the legs, look at the legs?
Well, early on, I got interested in the legs for a whole different reason. I was trying to do a heart case, and the leg arteries were blocked. And because of that, the patient had leg ischemia, and that was a big problem. And I wanted to avoid that. But then the more I started to look at this, the more I realized there was a tremendous association. If you've got blocked arteries in the legs, you're very likely to have blocked arteries in the heart or blocked arteries going to the brain. Mm-hmm. And you're therefore more likely to have heart attacks and more likely to have stroke. And so then it became very obvious we could put our finger on a foot pulse. That's easily checked. But you can't put your finger on a heart pulse. And so many patients with no symptoms at all, not in their legs, not in their heart, not in their carotids, have decreased pulses in their feet. If they do, those are patients who are actually at much higher risk of having cardiovascular events. So that became very interesting for me to pursue that. As we did, we realized there was a profound association between the two. And then, of course, the next step came, how do we best treat these? A, medically, but secondly, how do we take the patients with really advanced disease who were otherwise scheduled to have a major amputation? And how do we solve that? How do we stop that from happening? Because amputation's pretty bad. You know, a lot of people, when their legs start to hurt because they're starving for blood, they say, cut it off because it just hurts so much. Here's the bad news. When you cut it off, it keeps hurting. Right. You have what's called phantom limb pain. And so it doesn't even get rid of the pain. But on top of that, there's a tremendous cost associated. Patients, when they have their legs cut off, the best centers in the world, if they have their leg cut off below the knee, there's between a 5 and 8% 30-day death rate. Above the knee, between 8 and 12% 30-day death rate. That's the best in the best of the best institutions. Almost half of those people are dead within a year. In addition to that, however, only about half of people who have an amputation for atherosclerotic disease, for blockages, will ever go on to get a prosthesis and walk again. The other half never walk again. And about 1/3 go straight to a nursing home. So amputation's more expensive, more morbid, has higher death rates, and if we can avoid it, it's something we want to do.
But you found a way to save, over the years, you've showed me pictures, and I think you have one tonight that you'll get to. You look at these legs, how do you save legs like that?
Well, there are many, many steps. The first step is making the diagnosis. The second step is then opening blood flow to a leg. Very important to get blood flow. Now, many people think that's the whole treatment, but it's not. Okay, once we've achieved blood flow, we have to curtail infection if there's any. We have to do what is called unloading. So if a person is putting extra pressure on that part of the foot, we have to work with other physicians like podiatrists to cushion the foot. We have to work with diabetologists to control blood sugars very carefully. So this really is a team effort when we have someone with critical limb ischemia, but it really does begin with getting blood flow. You know, for way too long, people would present with ulcers and they would get hyperbaric treatment or antibiotics or all of these other things. Those are all very important, but they're not step one. Step one is getting blood flow. The reason you have the problem in the first place is poor blood flow. The first part of the treatment is better blood flow. It's not all of the treatment. You have to do much more than that, but it is the starting point.
Well, once you get the blood flow, then you have to decide what's the best medicines to put the patient on. And it's not all the same, is it?
It's not, and it really does depend. For instance, one of the great drugs that we use in treating people who have blocked leg arteries is a drug called cilostazol. It's a phenomenal drug. It can result in really improving blood supply, but you can't use it in everybody. If you have a very poor heart function and you use this drug, you may cause someone to develop heart failure. So we have to be very careful with these drugs. Each and every one of these cases is a blank canvas, and you must make a painting on it.
I hear heart failure a lot. What is the exact definition of heart failure? What does that mean?
Well, there are many kinds of heart failure, but heart failure, in a generic term, means that the heart is unable to pump blood as fast as the blood is coming back to the heart. And so the blood may therefore back up into the lungs and make us short of breath, or back up into the legs and make us swell. But in general, when we say heart failure, that's what we're thinking of. And there are different kinds. There's systolic heart failure, diastolic, but in a general sense, the heart is unable to keep up with the blood arriving back from the legs and the rest of the body.
So you have to be really open-minded for each patient you see, because Martin Falls may not react the same as Jane Doe, correct?
In fact, that's predictable. There are general guidelines that we use, but as we use those general guidelines, we also have to tailor it to each person. But to be honest, that's part of what I like about the treatment, because I find that very interesting. There's still a lot of thought that has to go into how we treat each of these cases and how we cross them. Sometimes we cross the lesion in the same direction as blood flow. Sometimes we come in the opposite direction. Sometimes we come through little tiny bypass arteries and come backwards, such as that. But it really depends upon the presentation, the anatomy, whether there's infection in a given area. All of those things matter, and we plug those things, each of those independent variables, into the equation, and then we come up with a way to save a limb.
But it sounds to me like there's a lot of mapping. That is each patient different in that respect?
They are. For instance, we cannot, in everyone, utilize iodinated contrast media. That's what, if you typically get an angiogram, for instance, you get iodinated contrast media. Many people call that dye. It's not dye at all. It's clear and it's thick material. But some people can't take that. If your kidney function's really bad, you can't take it. If you've got severe allergic reactions, you can't take it. Well, we can, in those patients, use CO2, the same gas we blow out when we breathe out. We can use CO2 and make images. These images are different. They're like in the old days when we looked at the negative of a picture. It would be like looking at the negative of a picture. But from that, we can still tell if there's a blockage and where it is. And so we have to determine, is kidney function good enough to use iodinated contrast? If not, go to something like CO2. If that doesn't give a good enough image, for instance, if the patient is moving or there's overlying bile gas, then we can use ultrasound. But there are a whole sequence of steps that we use to get through. And so whereas in the early days, many patients we really could not treat, they were deemed too sick to treat, there's almost no such thing as a patient in today's world too sick to treat. The other thing was, for a surgical bypass, there always has to be a target vessel to bypass to. Well, if there were no target vessels, you couldn't do anything. In today's world with intervention, you can even treat in patients who have no target vessels because you create your own targets. It's a very interesting, the world has changed.
It's come so far in 20 or 30 years. since you've started.
It's really come very far in the last few years, to be honest. So many of these techniques have really blossomed, and now I think intervention and surgery are very complementary of each other, because there's some cases, try as you may, you simply cannot cross with intervention, and surgery may save the day there.
Right.
But fewer and fewer of those cases are really happening in today's world. But it's still very important to have first-rate surgery always available. But there's some cases where surgery can't be done, where intervention can be done, and the big winner in this is the patient, because patients who historically had major amputations are now routinely able to avoid those.
What we'll do when we come back from the break, you brought some slides. And when people see this foot, they're going to say, no way you saved it, but you did save it, did you?
We did.
That's incredible. So stick around. We're going to show you a slide when we come back, and a few different slides. And once again, we're very fortunate to have this kind of facility in Houma, but it's all over the world now. We'll be right back. Don't go away.